طيب معناها نحن نبدأ. خليني بس أقدم حضرتك. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everybody to this exceptional session that we added. And first, I would like to thank Dr. Sami Alrabiah for accepting this short notice invitation in order to do this wonderful session that I attended part of it in some of the conferences. This is why I asked him to present it, because actually he has a great experience in on NIDIC, let's say, and in general in treating irregular astigmatism and irregular cornea. Dr. Sami Alrabiah is consultant ophthalmologist and founder and owner of Alrabiah medical center or eye center, let's say, in Kuwait, in the Gulf. And he is one of the founders of ophthalmology in the Gulf area, because he is one of those, let's say, mentors with their great experience and training the doctors, let's say, in many other centers. So thank you, Dr. Sami Alrabiah, for joining us and for being with us. And we are really very much excited to learn from you the PTK and the Topoguided treatment on the NIDIC, how you do it. And I'm sure that you are going to present it in a way that we can even apply it on other platforms, not only on the NIDIC. Thank you, Dr. Sami, and the stage is yours.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Mazen, for this introduction. I'm really flattered. Today we're talking about the art of phototherapeutic keratectomy. I think it is art, phototherapeutic keratectomy. It's not just a science. Phototherapeutic keratectomy is to apply laser on the cornea, but not aiming for refractive error correction. We are trying to correct something else. And this PTK could be customized or be non-customized. Just plain PTK, it has a role. And we use it for irregular cornea. Also, we use it for regular cornea to induce irregular cornea. Now, what's the difference between plain and customized PTK? Plain PTK, as here we can see, the energy distribution is equal on every single part of the surface of the cornea. So every part of the surface will receive exactly the same energy and will be reduced exactly like its neighbor. So there is no change in the surface. It is just duplication of the surface. It goes exactly the same surface down. While in case of customized treatment, energy will be higher where we need it, and maybe there will be no energy where we don't need it. And by that, we can just remove part of the tissue and gradually until we reach to the regular corneal surface. Now, PTK is to treat irregular corneal shape, and this is indicated by topography aberrations, or irregular corneal function, and this is by wavefront aberration, or, as I said before, regular cornea to induce an irregular cornea. We have to know that not all the abnormalities should be corrected. Sometimes an aberration on part of the eye is compensated by another aberration on another part of the eye, and the net result is zero. So don't try to touch this. Don't try to remove this aberration, because you are going to be faced with the other half. And the other thing, that morphological changes, if you correct it, this may induce and will induce functional changes. Now, what are the etiology of corneal aberrations? It may be congenital, like anterior stromal and epithelial dystrophies, maybe like keratoconus, pellucid marginal degeneration, or maybe induced, like post-keratoplasty, post-RK, post-keratitis, band-shaped keratopathy, post-trauma, whatever. But the most thing which we see always is the post-LASIK, post-refractive, post-LASIK. If we do small treatment zone, we end up with spherical aberration. And if we have ectasia or we have decenter treatment, we end up with coma aberrations. There are other aberrations apart from this related to the flap, maybe flap folds, buttonholes, displacement of the flap. All these are aberrations can be corrected by PTK. We have to understand first, and then what type of PTK, and what to treat, and the technique of treatment, what about results, and the end will give it to you, the method, step by step, how to treat it. So how to read and understand. Now, if you look at this in the center, this is normal topography. Look at the distribution. It's equal from one side to the other side, and there is no changes in the colors. While in the other ones all around, you see there are a lot of changes of colors and there is no regularity. So here there's sharp topographic color and K-value changes. There are valleys and there are hills also. The symmetry between sectors of the cornea are lost. So this is the shape of the cornea. Now, about the function, it is, I'm sorry. About the function, we abnormal corneal function, we express it by wavefront aberration. What is the wavefront aberration? Is the difference between the actual wavefront of that patient compared to the ideal wavefront of a perfect ocular system. The ocular wavefront are divided either low order or high order, and the low order aberration that are correctable with glasses, like sphere and cylinder. These are low order aberrations. They are aberrations, but they are low order. The high order aberrations are uncorrectable with glasses. They are correctable with hard contact lenses and others. Anyway, and we should thank Zernike because he described it and he classified it in his pyramid. It's a big expansion, and he put it in a beautiful way, like that. If we start with 0 and first aberration, which really in ophthalmology we don't need it, but most probably in physics. But we start with the second order aberration, and we have 2 on the sides. One is oblique astigmatism, one is vertical astigmatism, and in between is the defocus, which is either hyperopia or myopia. And this second order aberration is the low order aberration. And this is the one where that is corrected by glasses. Now, anything below that, it goes into high order aberration. And we have the third order, fourth order, fifth order. Why we call it third? Because there are 3 aberrations. Look here, 1, 2, 3 here. And why we call it fourth? Because there are 4 aberrations. Why do we call it fifth? Because fifth, and they are divided into right and left. The one on your left side is the oblique, and the one on the right side is the cardinal, which is vertical. And in the center, we said the defocus here before, and once you go down, it is the spherical aberration and its degrees. So this is just to understand what does that mean. Now, how to measure it, how to read it, how to measure it. Many machines in the market can measure it, but I myself, I use the Galilei Shimflow as well as the OBD scan 3 of Nidec. Now, look at this picture. Definitely, this is keratoconus. You can see that. But also the machine, I asked the machine to give me, what about the coma? What about the spherical aberration? What about the trefoil? It is only the coma was slightly high, 0.57, but the spherical aberration and the trefoil are not high that much. And this is another patient. This is what we call a nipple. Look at how small it is. Being so nice nipple. Now look at the spherical aberration, got really higher, as well as the coma and the trefoil. We can forget about that. We can just look at the Zernike map. Look at the coma is high. Both number 7 and 8, these are the vertical and oblique coma. And look at number 12, spherical aberration is still very high. Normal is about 0.3, but here you have -3, 1, and 1. So this is a very high number. You can read that and you know how is it. Now, if you look at this one is post-myopic correction. And you can see that the coma is 0.2, 0.3, very good coma. So it's not the problem here. What's the problem is the spherical aberration is slightly high, 0.4. spherical aberration here. And this is because of the treatment is small. And that's why maybe the patient is unhappy at night. Now, if you look at this picture, it seems to be high astigmatism. Oh, you think a lot of problems, but look at the high error. All of them are low. So the patient really has excellent vision if you correct this one. And the other picture also. So you can see the high orders. Once the high orders are low, the patient has very good chance of excellent vision. And this is the shim flow. You can select. Now you select only the coma. Look at the number 1.2, so it's high. You can ignore it and select only the trefoil, still high, 1.3. Let us look at the spherical. Spherical is low, is 0.12. So you can select which one, you can know which one is high, which one to 3. Now, what types of PTK? PTK is not just PTK. What types of PTK? PTK either customized or non-customized. Customized PTK may be topography guided or ocular wavefront guided, which is wavefront guided, or selective PTK. Selective PTK for selective errors, like for coma or for spherical aberration, only to correct spherical aberration, only to correct the coma, or to induce spherical aberration in case of presbyopia. Okay, and maybe you have non-customized, which is a plain PTK, and this also is divided into dry plain PTK and wet plain PTK. Even the wet is divided into thick wet and thin wet. We'll discuss all that soon. Now, the customized PTK, we said wavefront and topography guided. Wavefront takes the whole problem, the whole wavefront of the eye. So it goes through the pupil. So it is limited with the pupil center. And it corrects the wavefront aberration. Yet it is a tissue saver. It is excellent. It doesn't eat too much tissue. While the topography guided, it looks at the morphology, and it is at the center of the cornea. It has nothing to do with the pupil, and it is tissue consumer. It takes much more tissue. So you have to sometimes select between this and that, which one is good for your patient. Now let us look at this patient. This abnormal shape of the cornea. If you do topography guided, the shape will be excellent, but too much tissue. If you do wavefront guided, it doesn't look at the shape. It looks at the function, less tissue. Now, what is about the visual axis? What's the difference between visual axis and pupillary axis? When you take the picture of the patient, you ask the patient to look at the center of your machine. So you are depending on the visual axis. So your topography is on this cross on the visual axis. It has nothing to do with the center of the pupil. So if you are going to treat, you have to treat on the visual axis, not on the center of the pupil. But if you do wavefront total, it goes by default into the center of the pupil. So you have to shift the treatment of, if you are going to use wavefront, shift the treatment from the center of the pupil to the visual axis. And this is not really a problem. All the machines now, you can work on the machine and shift here from the site of the center of the pupil to the visual axis. And down here, this is exactly what you see on your surgery. This is the center of the pupil, and here is the treatment. You can see it is shifted. All these are basics. Now, whatever we talk, we are really unsatisfactory. Why is that? Because we are looking at the ice, the tip of the iceberg. We don't see the whole problem down. We are just looking up here. So what's going on? The epithelium is covering a lot of the problem. Now look at this mountain. You can look at the snow here. It's covering the irregularities down. It looks to be smooth and nice. But really, if there is no snow here, it will show how irregular the surface is. You can see that this is the corneal stromal surface, and it is nicely corrected by the epithelium. Of course, epithelium cannot correct everything, Otherwise, it will not have problems, but it will do its best to correct as much as possible. So, a corneal stromal defect are filled with epithelial cells. Irregular stroma means irregular epithelium, means irregular topography. And I would present with irregular topography means that the epithelium has done its best to correct whatever it can. Maximum function of the epithelium is done. So we cannot depend 100% on both of them to understand the irregularity of the stroma. Also, another point that not only epithelial masking is a problem, there is different rate of ablation between epithelium and stroma. Once you apply your laser, it is on the stroma different from the ablation rate on the epithelium. Now, this is the same eye, but the first picture here with the epithelium on, here epithelium off. And if you look carefully, look at the K readings, 45. But once you remove the epithelium, it is 47. How come? Because you exposed really the sharp case. Also, look at the astigmatism with the snow again. It is 1.5. Without, when you expose it, it's about 3 degrees of astigmatism. What to treat? Not everything. You treat only the irregularity that affecting the visual acuity, the quality of vision. If it's not affecting, forget it. And then you have to have enough tissue. Don't just shoot on the expense of the tissue. And you don't correct the aberration by inducing another one. Now, treat irregular cornea for what? Is it pure shape problem or pure function? Or, as usual, mix between function and shape. Pure shape means you have to look at the topography. Pure function, you have to look at the wavefront. But if they are mixed, then you have to select between both.
Dr. Sami,
may
I ask you, please, when you say wavefront here, do you mean the ocular wavefront?
Yes, because topography is not a wavefront.
Exactly. Yeah, thank you.
Topography guided is not a wavefront. Wavefront means you take the whole wavefront of the eye.
Yes, okay.
Okay.
Thank you. Yeah.
Thank you. Now, before we start to treat whether wavefront or topography guided, we have to make good, precise registration. Registration of the location and the degree of the corneal aberration. And also we know that cyclotorsion is a very important patient. Whenever he lies on the bed, the eye rotates, and you have to know the cyclotorsion. If you don't have that, don't do it, because precise registration will allow you to treat irregular cornea. But more important than that, registration will prevent you from developing high-order aberration in normal cornea if you are treating normal cornea by mistake. Now we are going to business. So all this was introduction. Correction of pure corneal shape. So we divide it into corneal shape, corneal function, and mixed. This is the art comes here. Only shape, corneal topography. Topography guided PTK. It's not wavefront. Now, what is this? This is the black window. Once you apply your laser on the cornea, on the surface of the epithelium, it fluoresces. It gives you the blue color. And you keep shooting until the black spot starts. Black spots means that there is no more epithelium, that you reach the stroma. So you have, this is the most, if you don't know this, or you don't see it, you did not think that's important. And if it is in the center of this, okay, we forget about this. We'll continue. Now,
Dr. Sami, would you please repeat again last slide, because your connection was lost. So when you reach the stroma, the spots will become black, you said?
Yes, once you finish with the epithelium. So what is under the epithelium is stroma. So once you finish the epithelium, once you reach the stroma, it gets black in color because the stroma does not fluorescent. So how do you know that you reach your stroma if you have this black spot? Is that clear?
Yeah. And now when you say PTK, for example, topoguided PTK, do you mean trans-epithelial topoguided treatment, correct?
Okay. We said we said we have many types. Some of them are transepithelium, some of them not transepithelium.
Are not. Okay. So when you say PTK, what do you mean by PTK?
For
The usual PTK, what you know?
therapeutic keratectomy. No, PTK is any type of laser you apply to the cornea with intention not to treat myopia, hyperopia, or astigmatism. Not spherical, not refractive.
So this is another way of terminology, I mean, because maybe some of the audience will be confused, because what we know, PTK is just to remove the epithelium and some of the irregularities in different ways.
No, my dear. The epithelium may be your friend, so you may use it in your treatment, and it may be your enemy, so you have to remove it to show up your pathology. I'm going to discuss all these points.
Okay, so I'll keep my question to the last. Maybe you will clarify everything during the presentation. Inshallah. Thank you very much.
Now this is just a diagram to show that how the epithelium is lost. Now this is the first, the high part, and then bigger part. As long as you are exposing more and more laser, until it remove it all. So it takes it with the mountains, the higher part taken first. Now, technique of treatment of PTK for only topographic changes. Either you remove the epithelium, do stromal topography, and customize PTK, which is impossible. Or you do trans-epithelial, this is answering you, plain PTK. So this is not customized PTK. Trans-epithelial plain PTK, okay? Not customized, trans-epithelial plain. And this is divided into dry PTK, wet PTK with thick masking agent, or wet PTK with thin fluid like PSS. So 3 types of transepithelial plain PTK. The dry PTK, which is with no fluid, just on the epithelium, this is for wide irregular surface. While the wet thick masking agent effect, when you have sharp multiple hot points, we will discuss it. It's just, I'm preparing you. And the wet thin, with thin fluid, this is if you have fine multiple surface irregularity. In this stage, you have to remove the epithelium. So number 3, you have to remove the epithelium. But number 1 and 2, you keep the epithelium. Let us see again. Now, what is this beautiful picture? This is the white one. This is the first one here, higher. It is the dry PTK without no fluid. It is just a big surface to be removed, surrounded by clear surface. And this is like keratoconus here. So you want to attack this. You don't remove the epithelium all around here. You just go and treat this. We will see it not soon. And this is the dry. The wet PTK with thick fluid, because if you look at the mountains here, there are a lot of sharp multiple hot points, and they are different directions. You cannot, it's not like smooth like that. It is just go up and down. So here you have to have thick fluids. And what about the last one? Last one is again wet PTK, but then here we use thin fluid like PSS. Again, we will say it one by one. Now, the one which is no masking agent, which we said we have large smooth surface, like in here, large smooth surface. So we reduce as much as possible to reduce the wide irregular surface as much as we can. Look now at now look carefully here. Now we are applying the laser. You will see the black spot soon, and you will see it's not at the center. It is at the apex of the cone. You look at it starting now. I'm sorry. Back. Here we are. Now, you will see that the breakup is not in the center, it's at the apex of the cone. And then you keep on taking as much as you can of the cone. طبعا it has a limit. The limit is around 55 micron. Look at it. We are taking only the cone, and then look at the other tip there. And that's it. So we finished now. We took it. Okay? But this one is different. This one is not smooth surface like the keratoconus. Look here, like a scar, we said. Okay? Technique here, and exactly like you look at the picture. Very, very irregular corneal surface. So here we use the thick masking agent. It's still transepithelial, plain PTK with thick masking agent. And this is in case of sharp, multiple K difference like scar and trauma. Let us look at it. Now you will see I'm going to dry on the sides because I put the thick fluid. I want thick fluid to be distributed all around the cornea. So I'm trying to dry it all around to make it as much as possible to be thin, not thin, but homogeneous layer. And then when I apply, look at the irregularity. You see that? These rings? You see there are black and translucent. The black ones means that we already reached the stroma. The blue ones means that these are the troughs between the spikes. They're still there. So there are many sharp points. And then here we put the fluid. Look at the surface. We put the thick one. This is thick, you see that? And then we try to add some. We make it more or less regular, and then we reapply. So it is a technique. You put and treat until you look at it. The one which was with lines and lines, now they are disappearing. It become, you see that. It is much better than before. And this is also another one. This is here. Yeah. Now look here. You see that it is here. The breakup is down here. Down here means really at 12 o'clock because the patient is fit. Look at it. This is corneal graft with the scarring at the edge of the graft. Again, you can see that it was irregular. And then you have to put the drop of the thick solution, and then you may distribute it.
Dr. Sami, when you do the first step, for example, how many microns?
50.
50. Then you do irrigation and then another 50.
No. The total is 50, 55, 60. That's it.
Okay, so
the
10
first
by
step
10.
Huh?
So you do it, the steps.
No, I don't take 10 by 10 or 15 by 15. I look at the black spot. Once it becomes irregular, I stop and I add fluid. Because these are, as I said, the spikes. So it's not just go 10 by 10. You go, and once it is irregular, you know that you reach another spike, put another fluid and try to go down.
Mm-hmm. Interesting.
You see that now it is getting more smoother.
There is a question. It is plain or customized? No, this is the customized, correct?
No, plain.
Plain.
This is plain. This is all plain.
Uh-huh. And what is the optical zone here?
It's accordingly. You can go up to 7 or 8 or 9, according to the pathology.
So we can make it 3 millimeter, for example?
Sometimes I do that in corneal scarring.
Mm-hmm. Okay.
Okay, now I'll just go back to the question.
Another question.
No, I went back. I
50...
went back here.
Yeah.
When I said transepithelial,
Yeah.
plain PTK, not customized. This I said this before. So it is plain. All these are plain.
All these types are plain. Now, the
why
55
is that?
micron.
Why is that plain? Because this is only topography guided. This is not wavefront guided. We said the shape is affecting topography. So we do topography guided treatment. It's not wavefront. The plain customized PTK in case we need to correct wavefront error. This is not wavefront. This is shape. I'm correcting the shape.
Yeah,
okay?
But Dr. Sami, when we say topo-guided treatment, it means that there is a machine taking captures and then building profile of laser based on like wave light, for example, or so. You don't mean that type of topo-guided treatment. You mean that
no.
Yeah,
no,
we
no,
are
I'm
just changing the shape of the cornea by the PTK.
For the scar, yes.
Yeah,
okay?
And irregularities in general. Now, another question. Yeah, another question. Is this 55 micron that you mentioned after epithelial removal or included?
After. No. Epithelium here is my friend, my dear.
Yes. So you start on top of it. You don't remove it mechanically.
Yes. As long as there is epithelium, I'm not in danger. As long as there is fluorescence, so there is epithelium, I'm not still in a bad position.
All right.
Okay. Now somebody may ask me, what is the masking agent? The masking agent, it has to have an ablation rate similar to the stroma. It has to be transparent, quick spread and layers, and sterile and bioadhesive. Now, this is the technique. Look at here. Is that clear on you? This is the stroma and this is the epithelium. If you apply the laser up here, the laser will take it out. You will reach this stage. You will reach the tip. Here, the black window. Okay? Is that clear on monitor? Now, you will notice also that the epithelium here is being reduced because the epithelial rate is higher than the stroma. So it will eat some of the epithelium while it is just touching the stroma. If you continue, you will end up reaching here before you much faster than you induce really change there. That's why you have to put the thick fluid to make a new layer, and then you apply the laser on the thick fluid. Once it goes out, you put and add until you get the smooth surface. By that, the new epithelium will go up and will be okay. Now, this is, we explained it before, forget about this. And look at the shape. Here, this is the regular shape, and this is by the fluid, and only by 45 micron you could correct it into this shape. Again here, but this is so simple. This is corneal scar. It's only 3.4 micron. It gets to this picture once you corrected this scar. So this is topography guided. Again, this is post RK, post radial keratectomy, astigmatic, and you just add customized, plain PTK. Now, what is here? Here, if you look at the same case, before you treat and after you treat, the machine thought maybe a keratoconus. This one. Machine thought maybe keratoconus or pellucid marginal degeneration. While after the treatment, this all disappears. It's just myopic correction. This means that the topography correction may induce functional change. Again here, this is before, this is the quality of vision, and this is after the quality of vision. Again, there is functional change. Also here, look at the RMS. RMS was 1.7 at 3 millimeters. It became 0.4. RMS was 2.34, become 0.76. So even the RMS improved only with few microns, only by topography topographic correction. Now, this is the last one, which we said, if you remember, we said either the smooth or the sharp or the very fine ones. These are the very fine ones. And of course, when you saw that, Sands of Sahara comes to your mind, Sands of Sahara. But look at that. This is a patient who underwent LASIK somewhere, and it was complete flap. And because it was complete flap, it was not fixed very well, and it ended up with extensive folds. Now, if this is not complete flap, all what you do is open it, and you can milk it again. You just put BSS or solution to hydrate it, and then you iron it. It goes back. But the problem here that it was free. You cannot remove it out. So you have to correct whatever in the face. Now this is it. Look at it. So a lot of flaps, and now this is the one which we removed the epithelium. You remember we said epithelium, we may use it as a friend in the very big ones and in the sharp ones, but in the very thin ones we have to remove to expose it. And then we don't use thick fluid. Here we use the thin fluid, the BSS. Look at it. It really looks ugly, isn't it? And the patient has a Maddox effect. All the lights are Maddox effect. Now we put a BSS here. And we don't shoot the cornea. We shoot on the BSS itself. Shooting on the BSS, I used to call this tsunami, because shooting in the BSS, the laser induced the plasma. Every shot of laser induces a lot of plasma, which makes, let me explain this first. It makes the plasma, which is bubbles. And these bubbles expand and collapse in part of thousand of a second. So we have many bubbles that expands and collapse, expand and collapse. And this expansion and collapse in the fluid itself, it makes wave, mechanical wave that remove all this irregularity, all this fine irregularity. That's why I called it tsunami, because tsunami removed all the houses, cleaned out the area. Look at it. I'm sorry. Look at it. I'm sorry. Okay. Yes. So if we look carefully now, try to remember the shape, because it will be different shape in less than a minute. We are shooting on the fluid. How do you know in the fluid that we should not see the black spot, which means that we reach the stroma? Once we reach the stroma, we put another fluid. We induce the effect on the fluid. You see that? The sponge is full of fluid. I'm just putting a new layer. I don't want to reach the stroma. It's just on the fluid. And look at it. Do you remember how was it look like? How did it look like before?
How many microns, Dr. Sami?
Here?
When do you feel you need to stop? To stop ablation, I mean.
When you see it this way. When you see, you don't ablate the cornea. You ablate the fluid.
Yeah, I know. But when you ablate, when do you stop? For example, you program it 10 microns, 20 microns, or when you see something.
Yeah. I put it to 100, but I don't use the 100. I just use 10, putting fluids. Usually it takes less than 20, 30 microns, but on the fluid, not on the cornea.
Yeah.
And do you see the difference? It looks beautiful. Now, this is the shape. Now we said PTK, it is not customized. It is just PTK. Okay? Now, let us call let us talk about the pure function. We talk about the pure morphological, pure shape. Now about pure function. Here, the wavefront pathology, we have to treat the wavefront guided PTK. And the wavefront aberrations, for us, either pure spherical aberration, pure coma aberration, or mixed wavefront and topography. So both of them are affected. Pure spherical aberration, after LASIK, we do LASIK with a small optic zone, so the spherical aberration is high and the patient is not happy at night. Or maybe you induce high negative or less positive in order to increase the focal depth for presbyopia. Or maybe you have pure coma. In case of pure, you use only topography guided. Wavefront guided treatment. But if it is mixed, you have to select both. Now, if it is pure, so the epithelial shape and thickness are regular, and it has no rule in our technique. You can do it either on the surface, or you can open a flap and do it, because it is, the shape is normal. It is the function. Is that clear? It's different from the shape itself. Shape itself, you have to think about the epithelium. You have to, yes?
Yeah. So here we have a normal shape, but there is high order aberrations.
Yes.
But how can it be like the shape? Mm-hmm. Huh? The shape, how can it be? I mean,
I will show you. We have example here. But imagine a patient who underwent myopic correction, and you examine him. He's 20/20, but he says, "Doctor, I cannot drive at night."
So you mean that the shape is not irregular? It is like just because of a small optical zone or a large optical zone or something. Does the decentered optical zone fall here as well? Decentered because it causes coma?
Decentered treatment will induce coma, but here there is also change in shape.
Yes, correct.
So if you go to number 3, we said number 1 and 2, number 3 down, there's a coma aberration, but mixed. There is like ectasia and decentered treatment. So the shape and the function.
All right.
Super. Okay. So if it's only shape, epithelium is regular, no need to think about the epithelium. You can open a flap and treat it, or you can do it on top. Okay. Now, again, if you look at the wavefront, we said from the here, the most important things are these friends, which are the coma, vertical, horizontal, شوية trefoil here, some trefoil there, but spherical aberration is high. So these are 3 mostly, and few of the trefoils. Now, this is the shape, okay? This is the shape of keratoconus. You want to treat it. The machine change it into a topography, change it into a wavefront map. This wavefront map, we don't understand it, but this is the wavefront map that the machine was going to treat. So this is the treatment here, and the treatment will go to the errors in the map itself. And this will change it to another map, which still we cannot understand. But if we translate it back to topography, it goes to this shape. And this means that the topography has changed from that shape into that shape by just changing the wavefront error. So here, we changed shape by changing the wavefront error. Again, the same story. Look here, this one, change. This is the wavefront map, and the treatment goes to certain area, change it into a new wavefront map, which means regular astigmatism, not like that one. Not only regular, but also you can see that the astigmatism from 3.65 to 2.7, almost 1 degree astigmatism is less, beside becoming regular. And this is again, same story. Now, pure spherical aberration. Pure spherical aberration mostly after myopic laser correction. But sometimes we intend to reduce the positive or increase the negative for presbyopia treatment, increase the depth of focus. Now, quickly, we have to describe what does that mean, because many persons, they don't understand what does that mean, the positive and negative and so on. Suppose our cornea is rounded like that. So the light at the periphery will be refracted closer to the surface rather than to what is needed. And so the light from the center will go to the retina. The light from periphery will go further in front of the retina, away from the retina. And we are not going to able to see, but really this is not our story. Our story that the cornea here is flattened. The more you go away from the center, your cornea is getting flatter and flatter, and the light is shift instead of being down to the small area down here. This is normal cornea. But if you do laser treatment like this, it is flat in the center, steep at the periphery. Look at it. It is getting steeper at the periphery. We said we wanted to be flatter at the periphery. Now you make it steeper. So again, you lifted the light up. And this is opposite. This is the cornea that you did hyperopic correction. So it becomes steep at the center and flat at the periphery. Again, flat at the periphery. So you made it flatter at the periphery, and the light goes down closer to the, so less positive spherical aberration. Again, this is steeper, this is flatter, this is post-myopic, this is post-hyperopic treatment. And this is the same story. Now, if we understand this, we will understand everything. This is if the cornea is rounded, is spherical. The light will be refracted here. But the peripheral light, I mean. But our cornea is not like that. Our cornea is normal prolate. It is flattened. So the light is pushed down here. It's still spherical, but not high. This is high spherical, and this is good spherical. You might ask me, but this is not on the center, not on the retina. Why we are happy? Because we forgot about the lens. The lens will add extra pushing down. So the lens and the peripheral cornea will make the light from the periphery goes up to the retina. This is a normal person. Now, what about these? This is if you do myopic correction. So the flat area here will be more steep or less flat. We can say less flat or more steep, whatever. And the light will, and the light instead of here will be shift up. And if we put the lens here, will be shift up. So high positive spherical aberration. On the other side, if you make this flattening more flattened by hyperopic correction, the light which is here will go down, so it is low positive spherical. So in all the cases about the cornea, there are positive spherical aberration, whether normal or high positive or higher positive or less positive. And if we put the lens, it should be zero. And this is the positive. Look at it, how it's raised. And this is, if it is all on the cornea, this is a good level. And then if we treat it, what we are going to treat it, this is a wavefront. If we treat it with topography guided, the shape is okay, as we said. But look here at the spherical aberration. It was 0.69, it became 0.52. Really, I did nothing. But if you do it with wavefront treatment, it became 0.2. So I really reduced it by wavefront guided. The same here. Look at here, this is the topography guided, become almost zero. Here, no change, from 500 to 450, minimal change.
Dr. Sami,
again, the same. Hello.
When you say here in these two slides, topo-guided treatment, what do you mean by topo-guided treatment? The PTK that you were talking about?
No, I mean, if you use topo-guided treatment, you will not get any benefit.
Yeah, I know, but what's the meaning of Topoguided treatment here? It is the PTK that you mentioned before?
No, no, this is not PTK. This is Topoguided wavefront
So
treatment.
this is, yes, exactly. So this is the real Topoguided treatment. Okay, yeah,
Yes.
understood.
Okay, and we understand that the topography guided does nothing to this wavefront, to this spherical aberration. It's only the wavefront that corrects it. So pure high, we said pure. You remember we said pure high order best wavefront treatment, not topography guided treatment.
So you
Now,
mean you mean when we have pure spherical aberration, it's better to treat by ocular wavefront guided treatment, better than topo guided. But let's say
topo guided,
but let's say in wave light, for example, they treat as well the small optical zone by topo guided treatment to make it larger.
Yes, by topo. Yes, you can change the shape.
Yeah,
you can change the shape, but if you change the shape, you will need more extra energy. But if you do with wavefront, it's minimal microns.
Yes, okay? I agree with you. Topo guided treatment is more aggressive than ocular wavefront guided treatment. I agree with you.
Yes.
Okay.
Now about the reducing positive spherical aberration or increasing the negative spherical aberration for presbyopia. Now this is a patient, hyperopic patient, underwent treatment. He was 39, become 42. So you can understand, 30, he was 40, become 42. So we can understand that he improved by about 2 diopters treatment. So he was treated by 2 diopters. If you look carefully to the spherical aberration, from 0.24 becoming 0.54, minimal improvement by just treating hyperopia itself. So we are correcting hyperopia and we are correcting astigmatism. Minimal improvement. Now, the same patient, if we look at the spherical aberration here, and we are treating the wavefront error, not the spherical, still spherical. Wavefront error, you can see here, by 9 microns, improved from what was before 0.54 into 0.81. So even better if we just correct everything, still not yet touching the spherical aberration. Now look carefully here. We are going to treat the center only, the spherical aberration, and look at the value here. So when we correct that, the value jumps up to 245, 0.245, which was 0.01. So really, it's about 3-fold increase. And look here, this height was positive, 253, now become really negative, 440, negative. So you increase the depth of focus for this patient only by 10 microns down. Look here, only by 10 microns added here, you increase the depth of focus and add the patient good reading facilities. Again. Now here is spherical aberration 0.43, and it's corrected by just treatment into 134 without spherical aberration. Correct your spherical aberration, which looks like hyperopic correction, and it jumps up. Now look at the shape. By 15 microns only, you increased it. This is the best, and this is, I can explain much more. Now, this is an eye, and this patient has either to correct. We are going to correct. We corrected one eye fully. So this one eye, it is the same eye, but I'm telling to you, if I do this way, technique or that technique. Now, if you look at this picture here, this is 40 K, and here it was 44. So this means that I corrected between this one and this one 4 diopters. So this patient had for diopters correction and the big treatment zone, everything looks beautiful. But if you look at the other picture, here it is 42. So this means I corrected only 2.5 degrees. معناها I left the patient with minus 1.5 myopia here. You may say, okay, you made it monovision. صح؟ إن خليت 1 plano و 1 minus 1.5. You may think this is a monovision. Not really like that. If you look carefully to the Q value down here, small letters, it was minus 0.15. And if I'm going to treat for distance, I don't really change it. 0.18. So it's almost very equal. But when I do it for near, it's not only I left 2 diopters, I increased the Q value to minus 0.73. And so I really increased the depth of focus. Also, you can see that the treatment zone is much smaller than the treatment zone if I'm going to do for distance. So if you are going to treat a patient for distance, full correction, I mean big zone, and try not to change the Q value, but for near, make it small and try to add more correction to transition spherical aberration to induce more Q value negativity. And if you look carefully here, look at here it was minus 309, the spherical number 12, minus 309. So it is really high. If you look here, spherical minus 0.68. So the spherical aberration here is minimum, spherical aberration here is high, and this will induce more depth of focus. Now, let us look at this shape. This definitely, once you look here, you know that this patient has coma because there's decenter treatment. Also, because the treatment is small, he has also spherical aberration. Now, if you look carefully to the Zernike, what I did, I corrected only this part, only these few things, which are the coma and the spherical aberration. Only 17 point or 19.9 micron. I'm sorry, only 19.9, 20 micron. I could change this shape to that shape. I did not change the refractive power, 40 here, 40 there, but I changed it. So there is no more coma and there is no more spherical aberration, only by selective choosing which part to be treated. And
Dr. Sami,
here,
so in NIDEC, it is possible to choose the high order aberrations that you would like to treat, correct?
Yes.
By ocular wavefront.
Yes.
Oh, that's yeah, and even in the topography guided, but in the topography guided, we don't depend on the wavefront. It gives
sometimes
us
it's mixed. Yes, sometimes there's
when there is mixed.
So,
I see. I understand.
Still, we will have more examples. Okay, I hope I'm not bothering.
No, we are interested. But there is a question. Is there any simulator in the software so it can show you after treatment how the cornea will look like?
Yes. And accordingly, you decide to go this way or that way.
That's amazing.
Okay.
Yeah.
Do you want me to go back to one to show you the simulator, or that's it? I already passed on it.
Yeah. Okay. No problem.
Okay. Now again, look here. I increase the treatment zone, and also I reduce the spherical aberration. So if you look here to the spherical aberration from 117 to 0.095, but the most important is the coma, which is from 526, 0.526 into 0.184, only by selective treatment. Again, this is the patient, this is before, this is after, and this is the topography changes without anything, just selective treatment of these. Topography changes. You can see the spherical aberration here. It's not much change, but what is changed is the comma here. Look at the comma here, it's almost zero. The comma here, this one is improved. Now look at the function. Point of spread function is improving. There is no change in refraction. It's almost the same. But look at the quality of vision. From here, change it to there. Now, this is how to select. This is a patient with high order aberration. Look at the wavefront error, 2.63. This should not exceed 0.3. Yani if we say 300, this is 2,600. This is many, many times worse than normal person. So this patient without no treatment, look at the wavefront error, 2 point. So I said, let us try maybe the trefoil. And this is exactly what you asked me about, if there is simulator. Here we are. So if I put only trefoil, it corrected from 2.6 to 0.3, 2.3. Not bad, but not enough. So here, you can look at me, I did only the trefoil. Here, trefoil, 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 trefoil. Only trefoil, I corrected only here. This is not enough for me. So I look at the comma. Comma, it was 2.12, so high, improving only to 2.09, nothing. So I have to go and treat the comma. So I went back here and I treated the comma. When I treated the comma from 2.12 reduced to 0.7. Oh my God, look at the beauty here. So only by 41 microns, I could change the quality from comma from 2.1 into 0.75. And this is total higher order aberration, 2.6, 1.5, again, beautiful. But you may ask me, what is this? This is the total aberration. Total aberration means high order as well as low order. You will notice that it was 10 becoming 6. So you may say, why we left so much? No, what is left so much is left in the low order. Okay, so there is no enough tissue for you. This patient maybe have advanced keratoconus, there's no enough tissue, and he cannot, even with, you don't want to put him cornea graft, he doesn't want cornea graft for whatever reason. If you give him glasses, he doesn't see, the high order is so high. So with minimal tissue, you correct the higher orders, and then let him have glasses. Let him have an ICL or whatever you want. Now he'll be happy. Now he'll be better vision. You can correct the residual error by something else, not by corneal refractive surgery, but you corrected the main pathology or the worst. So main concern and for the quality of vision. If no enough tissue, only go for high order aberration. Now it is the same patient.
Sorry,
yes.
what was that case? Was it decentered?
Advanced keratoconus. Advanced keratoconus. Yeah. Now it is the same case. We are still in the same case. If you look carefully here to the treatment, it is the same. Again, the same case. I'm looking now at the root mean square value, which indicate the quality of the vision of this patient. It was 3.6 becoming 0.9 at 3 millimeters. It was 3.6 at 5 millimeters becoming 1.9. Definitely he is better. Definitely if you give him glasses or ICL or whatever, he's going to have better vision. Now, this is what you asked me about. What about if it is mixed, both topography as well as functional, like ectasia? This is exactly what you asked. Like decentered ablation, like pellucid marginal degeneration. Now here, you have to select both. If you look at the corneal topography guided or ocular wavefront guided, and then we apply, you will notice that really there is no much difference. It's the same tissue, maybe 5.7, 5.3. The shape only looks better, but it is the same function. So both modalities give the same improvement, but less tissue and less tissue consumption, ocular wavefront. And this is exactly the same. I don't want to waste time. The technique for mixed aberration. Now, first of all, go for plain PTK. Suppose you have keratoconus, tilted keratoconus, whatever. You go first for plain PTK. As we said earlier, this is to remove as much as possible of the irregularity. Plain PTK with the epithelium on to remove as much as possible of the cone itself. After that, second stage, you remove the epithelium and you go for customized PTK, like we discussed now. And that customized PTK is to reduce high order aberration. So first of all, I reduced the amount by plain PTK, and then I went for customized PTK to reduce the high order aberration. And then I look, do I have still some tissue to work or not? If I still have some tissue, I can try to correct as much as possible sphere or cylinder. So this is the way I go for it, and we will see it now. Now, this is a keratoconus patient. Here we are. So first change this irregular shape into a regular one. So change this irregular astigmatism to a regular astigmatism only by wavefront treatment, not by anything else. 44.8 microns. So by 44.8 micron, I could change that to that. This is the first step. You see, nothing else.
But did you? Yeah, just 1 second. Would you please go back to that slide? You did what here? Did you do topo-guided treatment or the plain PTK?
No. The plain PTK is the first. Plain PTK has nothing to do with this. Plain PTK is to reduce as much as possible of the cone.
Great.
Because
and
we
then
know
we wait.
We know epithelium is our enemy, is our friend, and is our enemy sometimes. So we use the epithelium as a friend to remove as much as possible. And up till now, I did not correct anything. And then I remove the epithelium, so it is minimal amount of the cone, or less amount of the cone, less distortion. And then I go for wavefront treatment to reduce the high order.
Let me understand it better. If you can go back to that slide, the slide before, please. Yes. Now, step 1, plain PTK, done. Same session, we are going to do the step 2, same session?
Yes, all.
Okay. Now, I remove the epithelium manually with step 2 or
after the plain PTK.
So after step 1, I remove the remaining of the epithelium, manually, correct?
Yes.
Manually by applying alcohol or just manually?
No, by scrubbing.
Oh, by scrubbing. Great.
Yes.
Now, step 3, how do we depend, how do you do the topography? Because now there is no epithelium. You take the patient to do topography?
No, I cannot. I really, it is so difficult to take the patient from one room, to take it to the other room, to put certain solution in it, because the cornea surface is severely irregular. Topography will not be good. Okay, I don't do that. I do it on my table first, on my desk first. I know I'm going to remove epithelium and move part of the cone, and then remove the epithelium, and then I'm going to do customized PTK for the residual. I know I'm not going to correct 100% because the epithelium has covered. What is shown to me on topography is really about 70% or 65% of the real problem there. So when I do customized PTK, I know there will be something more, but I'm not going to correct as much as possible. I'm lifted with certain tissue, but I'm trying to make.
So step 3 is step 3 is what? Step 3 is what?
If possible, if suppose before surgery his corneal thickness say 490 or 500, okay. The step 2 customized PTK takes only 20 micron, so I know I still have 30 microns in pocket or 40 microns in pocket. I can go to correct some sphere cylinder.
Mm.
But if the cornea
Okay.
is thin and I don't have it, I just stop at the customized PTK.
Mm.
That's why I call it an art. It is not just A, B, C. Every case is different. Now, so here we change it from irregular to regular. Again, this is same, change it from irregular to regular astigmatism. But here,
this is by simulation, yes. Correct? This is simulation.
Yes, yes, but this is exactly what you see it later.
Mm. Okay.
Okay. Now he has astigmatism here. So why not, if we have some tissue, let us treat this astigmatism. If you look carefully there, here, there is no treatment, 0, 0. I did laser setting is nothing. Mm. And there is no cylinder and no sphere correction. It's only irregular astigmatism, irregular ablation, okay? I put some astigmatism, which is +3. This is what I end up. Look at the root mean square value. 1.2 becoming 0.6. 2.35 becoming 0.67. So the quality is really improving. Only by 24 microns here, and how much here is 0.5 in the center, because this is hyperbolic correction. So with minimal tissue control, we can get better results. Again, the steps from irregular, change it to regular by topography guide. And then try to correct the astigmatism to get good result. But really, this astigmatism, if we look here, the cylinder will take 84 microns, which is too much. I cannot accept that. So I have to reduce the treatment zone here to get better. Look here, I reduced it to become 39 microns. And before it was 48, now it becomes 39, and it is small zone and very well corrected. Astigmatism 3.68 becoming 0.36.
Dr. Sami, when you say topoguided ablation, here you mean the PTK, the plain PTK.
Plain PTK only to remove the tip of the cone.
Yeah, I know, but here you mentioned on the slide, you mentioned topography guided ablation, correct?
When?
The other slide. Yeah, this one. This slide, topography guided ablation on the top.
Topography guided, yes.
Yeah, so this is, you don't mean the topo-guided treatment. You mean the plain PTK, correct?
No. This is topography guided.
But this is step 3, correct?
Yes.
But step 3 is only spherocylinder.
Okay.
Now,
step one.
Step one is what?
Step 1 is epithelial removal. Forget it.
Yeah, plain.
This
plain
is not
PTK.
counted.
Plain
and
PTK.
then topography guided to change it from irregular to regular.
But how do you take the topo guided after the epithelium removal?
I know it is not 100. I know it's not 100%.
Yeah, but how do you measure it? I mean, before removal of the epithelium, when you see the patient.
Yes, before. Before on table. Before on the machine itself. Before even I remove. Before even I proceed for PTK.
Yeah, but after you remove the epithelium with the PTK, all right.
Yes.
You are now applying a profile that was measured on from a surface which is different from what you are applying now. So you are applying something irrelevant.
It is not much different. It is not much different. We know that the epithelium reduces the error. So suppose you have say 100% error, the epithelium will make it only 40. So when you remove the epithelium and you treat the only 40, because this is what you have in your hand, you measured it on when the epithelium is on. So you are not removing everything. You know that.
Okay.
I hope I reached.
Yeah,
Maybe
yeah, okay.
I couldn't tell you.
No problem. Yeah.
See, all topography guided. All of this are topography guided لأن هذا shape. طيب. Now this is another one. أول شيء first of all we do treatment which is topography guided, and then this will change it, the astigmatism from 7 to 4 here by treatment. And then step 1 is to treat the astigmatism. We change it from irregular to regular astigmatism. Stage 2, we add on top. I need you to look here with me. Here, if you look carefully, what I'm doing here, only 3 and 5, 11 and 13, which means astigmatism, okay? So by correcting the astigmatism alone, you can see here the shape of astigmatic correction. And this changed it from 7 to 4. So by 17 micron here, I could change astigmatism from 7 to 3, but selecting the astigmatism. This is step 1. Step 2, I added the comma. You see the comma? Number here and there, number 11, and number 12. Also comma here, number 23, number 24 on the Zernike. So I added the comma. When I added the comma, it is getting higher there, and even the astigmatism is reduced more. Then I can add, if I have tissue, I can add extra treatment. This is not this is just treatment. This is not wavefront. I can add extra treatment astigmatism to get even better result. And this is the shape of how does it look like.
Dr. Sami, do you have, maybe you are going to show us real cases now after the operation, how they appear?
Okay, I'll show you here. If you don't, it's not clear there, I'll try, because that one is not connected to net.
No. This one is clear now. Everything is clear, doctor. So you are going to show us real cases here. I mean, how they look like after the operation, correct?
Inshallah.
Yeah.
Inshallah.
Yeah.
Okay. So this is pre-op, post-operative 1. Look at the dates here. هذا 2012, 2013, 2012, 2013, 2014. This is after treatment. There is 1 year between this one and that one. Really, there is no gross changes. 37.96, 37.88. It is stable all the way. And this is the difference between the 2 visits. It's almost nothing. And this is keratoconus after cross linkings. And then after the PTK, you can see the wavefront error. It was 0.5 because only stabilization. Now it is 1.9, so it's improving. And this is keratoconus with improvement difference. But you want to see, yeah, this is also nice. Now, these are the real cases, and you can see the dates, huh? How does it look like?
Very good.
Some of them are amazing. Yes, salatu wassalam ala Sayyidina Muhammad.
Jazakallah kul khair. Thank you very much. Really, it was an amazing presentation. Will you please stop sharing, Dr. Sami?
Okay. Sharing. I stop?
Yeah, just to see your picture in full. No?
وأنا غشيم.
على سلامتك.
في view share وفي stop video.
Yeah, I can do it for myself. Yeah, done.
Okay, that's beautiful.
Great. So Thank you very much, Dr. Sami. Now, in order just to organize the things in my mind, and of course, audience as well. Now, let's say we have seen you doing 3 types of treatment: the PTK, the topo-guided treatment, and the ocular wavefront guided treatment. All right, in general, you mentioned 3 types. Now, when we want, and of course, everything is clear in the presentation, when to do this, when to do this, when to do that. But if we want to mix, if we want to make the step 1, 2, 3 in the last part of the presentation, so we do the PTK, plain PTK, as a step 1 in order to reduce the irregularities, and then step 2 is topo-guided treatment.
Yes.
Correct? Why not wavefront guided treatment?
Yes, you have to apply both on your simulator, and then you look at the result, which is better for this patient, whether it is topo-guided or wavefront guided.
And then step 3 is to add low order aberration, which is the sphere, cylinder, both.
If you have tissue.
If you have tissue.
Yes.
Now, first, I was not convinced with this until I saw the results, all right? Because we have been taught for a long period of time that when you take the picture or you build the profile of the topo-guided or the ocular wavefront guided, it is built on the eye before we touch it. Now we are applying this one after we do the PTK, which means that we are not working on the same surface. But
yes.
But we can see that still we can get results.
Because what you see on your surface is far less the pathology because of the epithelium.
Yeah, but does that cause overcorrection? Because already we reduced by step 1 some of the irregularities, and we are still applying the same profile. So does it do any overcorrection?
No, you are limited with tissue. You cannot just go ahead. You cannot do that.
In step 2, since we are going to apply the topo-guided profile or the wavefront guided profile, we are applying it on the very irregular cornea. But we already in step 1 reduced the irregularity. So
how much you reduced? How much?
Yes,
because
tell me.
Yeah, you correct. You don't exceed 60 micron. Okay, sometimes 30 is enough. Once you break up, you are touching the stroma, the black spot, and you go ahead with this until you reach 50, 55, and that's it. Stop. So how much you have corrected? You may be corrected 20%, 10%, 15%, but you know that still a lot there covered by the epithelium, and whatever you do, you will not reach everything.
But in step 2, you remove the epithelium, the surrounding or the remaining of the epithelium. All right.
Yes.
Now, in the example you showed regarding the distorted flap, because it was free flap, you removed the epithelium. The removal was by alcohol or mechanical?
Yes. No. It was with alcohol. I was afraid to dislodge it.
Yeah. Why not to do trans PTK in such cases? So no need to remove anything.
No, because the epithelium here, if you stain the patient, you see nothing. You see the patient was complaining of the Maddox effect. And if you put him on slit lamp, you hardly see it. And then only by retro-illumination, you can start feeling it. So the epithelium is really doing a very good job, but still not covering everything. And if you do transepithelial, you may not do it. But if you just remove the epithelium by few alcohol, and then you can do the tsunami.
Yeah, very good. Let me see if any of the audience have. I tried to, of course, to ask all the questions of the audience during the attendees. I mean, what is the maximum Kmax to go for PTK and wavefront guided treatment for keratoconus? So, do you have any upper limitation of keratoconus? No.
No.
But thickness
The
is the
higher,
guide.
the higher the K readings mean that the less epithelial covering, and you will reach. Yeah.
Exactly. This is why you make it dry. Some people may say, why not to cover the cornea by wet and do the PTK? Because you don't need, because the epithelium is very thin over the peak and thick over the trough. So whenever you start ablation, it will ablate, for example, 20, 30 microns, and then starts to touch the peak of the cone while the other parts are still covered by the snow. It was very nice example that you showed us the snow, and really it was an amazing example. Sanaria says, what are the guidelines for PTK in brief, in your way, guidelines?
Guideline, I think.
So let's say
treat only the pathology that affect the visual quality. Don't over-treat what you see, because one may be correcting the other one. Do you know that if you have astigmatism with the rule, as well as coma, vertical coma, they compensate each other? If you are trying to correct the vertical coma, you will have the very high astigmatism. So be limited. Look exactly what you treat. Don't just push yourself.
Very good. And what is the minimum? What is the maximum ablation by the PTK? Is it 50 to 55 microns, and that's it?
No. 50 to 50 PTK up to the surface, up to the cone. I may take 20 microns, but how much I work on the stroma itself? Yes, this is 50 microns. Sometimes really I'm generous more, especially if this patient was crossed before and he's been with me for a few years and that he's stable all the time. I think his cornea can resist taking some more.
Great. Now Hassan says, why not just wavefront guided treatment without PTK? What is the advantage of PTK first? Dr. Sami mentioned that this will reduce the irregularity and at the same time will remove the epithelium. So anything to add, Dr. Sami?
Yeah. Yes, just to
reduce the irregularity. Great. And
we have to know again and again and again that what we see in topography is far less the real. So if we remove the epithelium and start attacking, we'll do nothing more than 30-40%. But if we leave the epithelium, we remove as much as we can from the cone, and then we try, maybe we can reach 50-60% correction.
Another question, when you use the Nidec Quest machine, do you use the OPA or Fine Fit for your regular cases?
My regular cases? This is a very good question. OPA is tissue saver. So when I do correction and I calculate if the percentage is the 40% is exceeding the 40%, so I just change to OPA. But I have my own regime. I just don't put the data into the OPA. What I do it on the final fit, on both wavefront guided, because I do all wavefront guided. I mean, in both topography guided as well as wavefront guided. I take the K readings in both cases. I take how much tissue I eat in both cases. I look at the wavefront error total in both cases, and then I write them in a piece of paper. Then I go to the OPA and apply it. I have to have almost the same, because if you apply the same on OPA, it gives you under correction. Definitely it gives you under correction. So I go myself and I go for the K readings. I reach the same K readings. And after I reach the same K readings, I look back again to the refractive error, try to close it. And then if I look at the total tissue loss, at least 20 to 25 microns are saved. So OPA is excellent, but the quality is better with the final fit. Final fit, I feel it in my hand easier.
Yeah, of course. Always the optimized is better than the tissue saving. But now on the NIDIC, does it use the plus cylinder equation in treatment or the cross cylinder?
Cross cylinder.
The OPA is cross cylinder or all?
No, OPA has no plus.
No plus, OPA no plus. So it should be cross cylinder then. Yeah. All right. So
no cross cylinder. If there is any plus in your refraction, it does not correct it by OPA. Because cross cylinder.
Okay, so if you have, for example, +1, +2 cylinder, OPA
forget
cannot.
about OPA. No.
And if you have +1, -2 mixed astigmatism, OPA cannot.
No.
Okay,
and
for the
if you have plano, if you have plano and minus say 3, OPA cannot. Why is that? Because it does not accept a plano. It has to be all in myopia. But keep in mind, if you have say minus 0.5 and then minus 3, correction of the minus 3 will have effect on the sphere. And minus 3 on my hand will give me about 1 diopter hyperopic. So 1 diopter hyperopic, and there was already minus 0.5. So I'm going to end up with plus 0.5. So the OPA is not accepted here.
All right. Is trans-PRK one or 2 steps in NIDIC? The trans-PRK, if you want to do trans-PRK, do you plan it as PTK, then PRK, or it is just 1 step? Dr. Sami. Dr. Sami, maybe the connection. Yeah, the connection.
Yes.
Now, the trans-PRK is only 1 step, or
trans-epithelial PRK, you mean?
Yeah, trans-PRK, yes, trans-epithelial PRK. Dr. Sami.
Well, why I do trans-epithelial PRK and BTK in all cases of PRK. Okay? Is that, do you hear me?
Yes.
Okay. Unless the sphere is less than -1. Because trans-epithelial PRK corrects -1 sphere. So if the patient is minus 0.75 and you do trans-epithelial PRK, he'll end up with plus. Am I clear or not yet? Trans-epithelial, okay. Trans-epithelial PRK, I do it since maybe 15, 20 years. Okay. What I do, I apply the laser on the epithelium until I see the breakpoint, which is exactly I showed you. And I wait until my breakpoint is about 3 by 3, circle about 3 millimeters. At this stage, I know that I removed almost all the epithelium in the center, and what is left is very fine layer of epithelium at the periphery. By just dry sponge, I just wrap the cornea, and this epithelium will go out, and then I apply the laser for treatment. But here you have to keep in mind, if your prescription is -2, you will, and you are going to do PTK, you will say PTK, then this -2, you have to make it -1, because -1 of it is removed already by the PTK.
Yeah,
And
yeah,
then,
understood.
so you do.
Understood. Okay, so it is 2 steps. Now, another
Yeah,
question.
One step.
You program it 1 step. You program it. It is 1 step.
Ah, la. You put 4 or 5 lines because you go for PTK first, and then you go for correction, and then you
Yeah.
go for wavefront, and then you go for PTK. I do PTK for all the cases after I finish.
Yeah, to smoothen the surface.
Yes, and also to reduce the haze, especially in hyperopic, especially in hyperopic. Especially even if it is not PRK, not surface treatment, even if it's femtolasic, I do PTK after hyperopic.
PTK on the stroma.
Yes.
On the stroma. And
yes,
how many microns?
3.6.
That's
But
it,
9 millimeters. But
yes,
9 millimeters.
Exactly. I heard this technique from others as well in order to reduce the haziness and to reduce the induced high order aberrations. Correct?
Dr. Sinjab, I haven't seen haze for the last 12 years.
MashaAllah.
Alhamdulillah.
MashaAllah. Alhamdulillah.
But also I have my way of mitomycin. I have my timing of mitomycin, not just as they said, 20 seconds and that's it. No, mitomycin exactly like when we used to do it in trabeculectomy. Okay, you remember? It's different according to the age, different according to the sex, to the color of the patient. It's different according if the patient has previous trauma or not, surgery or not. All these factors will activate your fibroblast. So all these factors will increase the timing of your mitomycin.
Yeah, sure. How to make the best of OPD3 machine?
I think OPD3 is one of the best machines I have ever used, but I don't want to say that, otherwise NIDIC will, I have to charge them anyway, because by the OPD, we can select the wavefront error, everyone alone. By the OPD, I can know if the problem of if the wavefront is it. I'm sorry. Do you see me?
Yes. We do.
Yes, I know. It can show you that the astigmatism is only corneal, anterior surface of the cornea, or total. It gives you both. So whenever you are going to put a lens and your astigmatism is, say your astigmatism on refraction is absolutely different from your topography, it tells you there is something inside the OPD. So you should not depend on both of these. Both of these are wrong. You have to go now to the Galilei to look at the total corneal astigmatism, axis, and power. It will tell you this. It will tell you also if the astigmatism is if the refractive error is on the surface of the cornea or the back of the cornea or the total of the eye. It also gives you the refractive error, like autoref. It will give you the topo. It will give you what is the incidence of pathology you have, whether it's lucid marginal or keratoconus or normal or whatever you have. It can show you all that. It can give you, if you want just alone the corneal study, you want to study the corneal asphericity before and after, you want to induce some asphericity or reduce some asphericity of the K value, you can do that through the OPD machine. You can have what is, you can see even the retro if the patient has cataract or has lens changes, you can see it with it, definitely by the retro illumination. The size of the pupil, it can tell you how far is the angle kappa, how big is it, and it can tell you also white to white if you need to measure it. So a lot of things you can have it from the OPD.
Okay, super. Now, Abdul Latif, Abdul Fattah, sorry, Abdul Fattah is asking if it is possible to reach you to ask you about some cases in NIDIC. He seems like a NIDIC user, so is it possible to send you an email, for example, or?
You know my email, Dr. Sami Alrabiah @gmail. اسمي موجود سامي ربيعة بس شيل ال سامي ربيعة @gmail.com.
Let me write it here.
Dr.
So Sami.
DR.
DR first, okay. Doc. Then.
Sami SAMI.
So one word, Dr. Sami, one word, correct? No dot.
Dr. Sami Alrabiah كلها one word.
L without L.
Without L. Sami Alrabiah.
في H آخر شيء. There is H. Okay.
بني ربيعة لازم H. @gmail.com.
gmail.com. Okay, I posted now for everybody who would like to reach Dr. Sami, who is very generous to offer this. MashaAllah, Dr. Sami is 50-year-old plus and still active, MashaAllah, very active, MashaAllah.
50 years plus 21. Alhamdulillah.
MashaAllah. طول العمر ما شاء الله. And he still attends conferences and discuss cases and give presentations, and so no limit to the number of years. صح؟ ما شاء الله.
الحمد لله. الحمد لله.
ربنا يزيدك إن شاء الله ويجعلنا وإياكم ممن طال عمره وحسن عمله إن شاء الله.
اللهم آمين. اللهم آمين.
Okay, thank you everybody, and would like to thank Dr. Sami for this wonderful experience that he shared with us, and many lessons that we learned from him. And thanks as well to all the attendees who attended the session. And I'm going then to do some edition to the video and upload it to the YouTube channel, inshallah. Have a good night, everybody. Wassalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام ورحمة الله وبركاته. في أمان الله. مع السلامة.
مع السلامة.